Right, what can the map do for us? So I've got a list of things here. These have sort of evolved, this list, and it is evolving. And if you've got any additional things to mention, I'm really glad to hear of them. The first one is the criteria. So sometimes I get referrals from some GPs are excellent and they give 3-4 page referrals, whereas others, I've had one referral which was, this patient came to my to the GP clinic today and they were very tearful in the clinic, could you please see? Yeah, so we have them. And again, with another one I'm getting a lot of these days is bipolar is very much in the media at the moment. So I'm getting a lot of patients with query bipolar, and there's a lot of people who think they've got bipolar these days. And actually, when they come to clinic, they haven't. Their mood is up and down on a minute-to-minute basis, and it's just a normal variation. But because they think there's something wrong with them, they've gone to the GP's referred them straight on. But if they had some guidance as to what bipolar was, maybe the referrals would decrease and we'd have more time to see the patients we would need to see for our level of specialism. So you can ask a question.
GPs already have, you might not be called a care pathway, but they already have guidelines for referring second care with depression, for example, and they don't follow those now. So what hope is there?
Sorry, I can probably help on that. We did a study at the Royal Free Hospital in the early days, and the major complaint from general practitioners was, again, silos of care pathways or referral criteria, different formats, different prominence. What led them to develop the map was exactly that issue. They wanted at least 100 topics developed through the same prominence structure, the same user interface, with the ability to localize and modify. So the map, if you like, was developed out of that issue.
So referral should be better.
I could also answer the question, but maybe when we put those all on one panel, it would be better so we can all give up as well.
Can we write that question down as well? By the way, all these questions are really good because I'm, to be honest with you, I'm learning a lot as well from the questions. By the way, I don't work for medicine. Really important thing to highlight. Okay, so that's one benefit. The next benefit is teaching our doctors evidence-based psychiatry, and I've mentioned that with my sort of junior doctor, and they can go through all the conditions and learn up-to-date evidence-based psychiatry. Empowering nursing staff. This is a really important one, and I've started doing. When I first came across this question about what's depression, and I thought, well, we should start teaching this. So certainly in our hospital, I teach the crisis resolution home treatment team once a week. The CMHT I teach once a week. So that's 2 to 3 hours of teaching every week for the nursing staff, and they've really benefited because they now know what depression is, and it just empowers them to not make a diagnosis, but at least, sometimes if, let's say for example, you're the gatekeeper and you've got patients who are coming to you, and the gatekeeper will send the severe ones onto psychiatrists, some they'll pass on to counselling, some for CBT and so on, and it really helps to know what a lot of these diagnoses are. The next one's helping our doctors. So this is junior doctors on an inpatient's ward. Sometimes you make referrals to the acute side and it can take a few days, a few weeks, you don't hear anything and the patients just sit there. Sometimes with not very serious conditions, even mild ones. I mean, for example, DVT, I wouldn't know what to do with one. I remember vaguely that you need something to thin the blood and melt the clot away and stuff, but all the exact protocols, I don't know. And if these protocols were there for junior doctors, for them to help them manage medical and surgical conditions on the ward, I think that would be really useful. It can help us keep to date with the latest evidence base. I try to read the Yellow Journal every month, but it can be quite difficult sometimes. And therefore, with some of the guidelines, it just helps. The map can help us there. And the last one's really important, helping us to manage patients with rare disorders. Certainly around what I've noticed in all my sort of training and where I'm up to so far is that patients with eating disorders, Asperger's, ADHD, and these other illnesses, which are we commissioned for them, are we not commissioned for them, who should be treating them, when should they be sent for, when should they have specialist referrals, and a lot of the times specialist referrals, they might not even have the BMI on them and stuff, so there should be a basic minimum there. And I think these pathways can be very useful for conditions that I personally don't know how to manage, I don't know very much about. Sorry.
But they're not rare disorders, they're actually more common disorders.
Oh, sorry, they're common, yeah, but It's just that we don't see much of them.
If we don't see them.
You're doing child psychiatry.
Sorry?
You're doing child psychiatry, that's, a third of our workload is those three things there, probably more in services where neurodevelopmental disorders are seen within cabs, it'll be 2/3 of our workload when you add in ADHD.
Yeah. So another thing I meant to say right at the start was, a lot of this is my practice and my observation, so this doesn't apply to everyone by any means of the imagination. It's just that I don't see many of these, so when I get them, I'm kind of scratching my head sometimes, knowing what to do. I have found out that there's a service in Sheffield now for adult Asperger's and autism spectrum disorders I can refer to. But these things, it'd be helpful if I knew that right at the start. So I think that the pathways can be useful for that as well. Can I have the next slide?